I brought along a couple of guests because I gathered from Monica that the discussion today is primarily about the fatigue clinic and I guess more particularly the activities that we attempt to do in the fatigue clinic. And so I've brought with me some of the team from the fatigue clinic. So at the front with specs on her brow, Rashana, who actually coordinates the Cancer Survivor Centre, and that overlaps with fatigue because there's quite a lot of what we might call post-cancer fatigue, which we're also interested in. And behind her is Carolina, who's an exercise physiologist, who's working in the fatigue clinic and also actually doing a PhD studying, you might talk about it, studying aspects of fatigue. And then Richard and Sarah, who are two of the clinical psychologists who work in the clinic and deliver part of the intervention that we're going to talk about. Okay. So if I've got it right, my brief is to talk a little bit about what we do, thank you, in the fatigue clinic, and then maybe give you an opportunity to ask questions, and actually we could talk about other stuff if you'd like to. So I might try and do 20 minutes worth, I guess, about the fatigue clinic and the intervention and the evidence and the underpinnings of it, and then we could see how we go with questions. Perfectly good from my point of view if you'd like to interrupt and ask questions, and then we can go a bit more free rein after that. So I think in order to talk about the fatigue clinic, I think I need to say a couple of things about my interpretation, hypothesis of what the biological basis of chronic fatigue syndrome is. Because it underpins what we do in the fatigue clinic. And then I might just talk a little bit about some of the existing evidence that comes from other sites across the globe about the sorts of things that we do in the fatigue clinic. And then a little bit about what we've been doing and how we're trying to work on improving the merits of the intervention. So my take on the biological basis of chronic fatigue syndrome is very biased by the fact that I'm an infectious diseases physician. And in particular, therefore, I'm quite interested in the relationship between infection and post-infective fatigue. And in broad terms, no one really knows this, but probably a third or maybe a half of all patients with chronic fatigue syndrome appear to have or have well-documented infection at the onset. And there's another proportion who might have, and another proportion where there's really no clue that an infection was the trigger. Downstream, they all kind of look the same from my side of the desk, but they seem to start in different ways.
And by infection, viral and bacterial, you're talking about?
Yes, it's probably not all infections. In fact, there's good evidence it's not all infections. So Simon Wesley, who's sometimes a controversial figure in the chronic fatigue syndrome world, is a psychiatrist from the UK. He did a very nice study ages ago, 15 years I think, where he followed a whole pile of patients from general practice who had either gastro or minor coughs and colds versus other random non-infective presentations.
What about the overexposure to chemicals?
Hang on a sec. Other random presentations to GP care, and what he showed is that there was no increase in the incidence of fatigue, and that contrasts quite a lot with the sorts of studies that I've been involved with and that Peter White from the UK have done, where we've followed people from the onset of an infection like glandular fever, where it's well documented, we're well, get fever, get a blood test, get diagnosed, followed longitudinally after that, where it's very clear that a range of different infections increase the likelihood that you'll subsequently be consistently unwell with bad fatigue for at least 6 months and meet the diagnostic criteria for chronic fatigue syndrome. And so the ones that we studied in the Dubbo study, that big cohort study that I led in Australia, were EBV, which causes glandular fever, Ross River virus, mosquito-borne thing that causes rash and arthritis, and actually a non-viral infection called Q fever, which is a bacterium that is common in cattle and sheep and transmits reasonably commonly to people who live on the land. So all three of those we showed were a trigger for a post-infective fatigue syndrome. So just jumping back to the discussion about the relationship between infections and fatigue. One of the things I would say about this is that we know quite a lot about the drivers, the things about acute infection that make people feel crook. So you know when you get a bad bout of the flu, like bird flu or swine flu, that sort of thing, generally what happens is that you feel as crook as a dog. You sleep a lot, aches and pains in your muscles, headaches, fevers, off your appetite. If you tried to do something hard, concentration-wise, you'd be in trouble. If you tried to go for a run around the block, you'd be in trouble. So all of that stuff is what we would call the acute sickness response. And it's actually not determined directly by the bug. It's not driven by the virus. It's an indirect consequence of the virus. It comes from the person, it comes from the body's immune system. And the good news about the immune system is it kind of works at trying to get rid of the bug. The bad news is that you get a price to pay. And the price that you pay are all those symptom manifestations. And those manifestations are pretty generic across a whole range of infectious diseases. One of the things that we showed in the Dubbo study that got us interested in this whole area, though, is that people who are going to be still crook with bad fatigue 6 months or 12 months down the track, that their fatigue and other symptoms, they all start on moment one of day one. So they're well, then they get an acute infection, and as part of that acute infection, they get the acute sickness response.
Andrew, can you just explain the Dubbo thing was on glandular fever?
Glandular fever, Ross River and Kew fever,
yeah.
3 bugs located in Dubbo, 800 people, followed longitudinally. And so the importance of all of that is that that means that the onset, the beginnings of the fatigue syndrome in people who will have post-infective fatigue, it starts in the acute infection. And in the acute infection, we know that those phenomena are driven by the body's immune system generating the acute sickness response. And the way it does that is by factors made in the body that act on the brain and make all these manifestations appear. So even though you might have terrible aches and pains when you've got influenza, we know there is absolutely no virus and no pathology in the muscle. So even though muscles hurt like hell, but there's absolutely no pathology in the muscles. It all comes from upstairs. And when I say upstairs, what we really mean is that there are cells in the brain whose job is to respond to these factors coming from the blood and then talk to neurons and ultimately give rise to fever or pain or fatigue or sleeping a lot or concentration difficulties. So my interpretation, our interpretation of chronic fatigue syndrome or post-infective fatigue syndrome is very biased by that paradigm, which says there's a problem in the brain which got initiated in the acute infection and then perpetuates. So it's not like the infection happened and then you get better and then something else happens and you get a fatigue syndrome. And one of the problems in the whole world of chronic fatigue syndrome is that we're not clear if that's generalisable to all chronic fatigue syndrome. We're not clear what the problem is in the brain. Because we know if we examine the brain structurally, like do a scan of a brain, and look for a big hole or something like that, nothing to find. There's occasionally some, what you might call unidentified bright objects, but nothing consistent or reliable. So the bottom line is, it's not like there's a big hole up there. And so what that means is that it has to be an abnormality in the brain at this level of cells or proteins, biochemistry within the brain. And so that's our idea. And another way to think about this, the idea is that part of the way your brain helps you manage to maintain your well-being is to keep tabs on how things are travelling in your body, how what we might call the physiology of your body is working. Is there a pin sticking into your arm and therefore you should pull your arm away? And so to do that, it has to know that there's a painful stimulus coming from the body and sending a message off to tell you to pull your arm away. And that sort of phenomenon, it has what we call a threshold. That's an idea where you could push the pin in just a little bit and you probably wouldn't even notice it. Push it in a bit more and you'd start to say, oh yeah, and then you push it in hard and it hurts. So there's a threshold for awareness of the pain. And we think about that in the same way with fatigue. There's a threshold by which your brain becomes consciously aware that you're fatigued, or you could say, excuse the parlance, that you're buggered. So there's a kind of a signal that goes off in your brain that says, oh, this is too much, I'm in trouble, I'm buggered, or I'm in pain, or something equivalent. And so the way we think about the fatigue syndrome and the disorder in the brain is that there's a disturbance and it changes those thresholds so that normal signals, absolutely perfectly normal signals which come to your brain all the time from the body, are kind of misinterpreted. So the threshold's got too low and these bad messages go off saying pain or fatigue or mess up your sleep or do all sorts of other bad things. So that notion, it has this kind of idea of thresholds, so that's a key element. Brain disturbance, thresholds. And we're pretty clueless about the nature of the disturbance at the cellular or the biochemical level in the brain. No one on the planet knows what the nature of the disturbance is. We're pretty sure there is one, but we just don't know what it is. And so then if I just jump slightly across to talk about the evidence for treatments in relation to chronic fatigue syndrome. You know there's like 101 double-blinded placebo-controlled trials. Everything you can think of has been trialled in one of those studies where they're randomised, so you kind of allocate patients to A or B, placebo or the real thing. Neither the doctor nor the patient knows which one they're getting. Everybody gets systematically evaluated. At the end of the study, the code's broken and you say, okay, is this wonder drug better than the placebo? That's what's called a randomised controlled trial. And so it's like more than 100 of those. And they cover antibiotics, antidepressants, vitamins, herbs, diets. Antivirals, everything you can think of. The bottom line out of all of those is that there really is no consistent evidence for anything as being curative. And when we say consistent evidence, our sort of gold standard in medicine in the 21st century is 2 independent centres, large-scale, well-designed studies showing the same outcome. That's what we call level 1 evidence. Top quality evidence, this is what you should do. So there's nothing like that in chronic fatigue syndrome. And so rather than thinking about the miracle cure, for better or for worse, we're trapped into doing stuff to try and manage the illness. So it's a kind of a different paradigm. So in the fatigue clinic, and in my head at least, we don't really think about cure. That's not that we've given up on the idea of people getting better, but just we don't think that there's any treatment that has scientific credibility that is curative. And so as soon as you're in that idea, then the question is, what can you do to relieve symptoms? And what can you do to improve people's lot in life despite the illness? And when I really say lot in life, what I really mean is improve their day-to-day capacity to do stuff, because that's really the limiting issue. You're too buggered or there's too much pain to get round and do stuff you'd like to do. Now, one of the small twists in the discussion is that it's pretty clear that what starts the ball rolling in post-infective fatigue or in chronic fatigue syndrome isn't always what perpetuates it. So other issues come along after the event, or sometimes simultaneously. So the big ticket items from our point of view in that regard, messed up sleep and wake patterns. So rather than sleeping in the black of the night, like the rest of the people on the planet, and being awake in the day, sometimes people start to, they kind of get this illness, they wake up in the morning and they feel pretty crappy. They say, oh God, I must have to sleep more. That's got to be the answer, they'll fix it kind of thing. And so then what they do is say, okay, look, I'll sleep later, or I'll have a sleep in the afternoon. And what we know from all sorts of independent volunteer sort of studies, if you do that, it's really bad for your nighttime sleep. Sooner or later, it'll go off the rails. And then you're on a total catch-22. So your nighttime sleep's getting worse, You're sleeping more in the daylight than in the black part of the night, and so that's a real catch-22. And it's a bit like the jet lag phenomenon. If you get out of sync with what we'd call your circadian rhythm, bad for you. Gives you symptoms like pain, fatigue, concentration difficulties, and so on. So that can definitely act as a confounder. And then secondly, we know that not everybody, but probably about 50% of all patients in the chronic fatigue syndrome arena, sooner or later in the course of their illness will develop mood disorder, depression or anxiety, for all sorts of reasons. Some of it, I reckon, is driven by the biology, by the brain being messed up. Some of it is driven by really tough circumstances. You know, the illness is pretty bad, no one believes you, there's no treatment, it's hard for your relationships, you lose your job, it's all pretty crappy from beginning to end. And so that's a bit of a downer. And it's quite anxiety provoking too, so people often start to understand that if they do a bit of stuff physically or cognitively, it makes the symptoms worse, and so they get worried, they get anxious to do anything. And that then can become a kind of a spiral. So you can see that those two things in particular, other things as well, but those two things in particular, sleep messed up and mood messed up, they can act as an exacerbator or perpetuator of the illness. And so we fuss about those. So that then takes me just to talk briefly about the evidence base for the sort of intervention that we do in the fatigue clinic. So you know that this goes by the name of cognitive behavioural therapy. I'm going to get into trouble from the clinical psychologists in the team here, because my sense in some ways is that cognitive behavioural therapy is a package deal of what I would call in many ways just good clinical care. So it's doing a set of stuff to help people understand their illness, you know, because we're pretty expert on it, so we help people to gain that same level of expertise, to understand about patterns of symptoms and how sleep and mood and other things can be confounders. And then to help them to develop strategies to better manage the illness. And we've got a pretty good understanding of that, because we know that overdoing it physically or cognitively or even emotionally can trigger exacerbations. And not everybody has cottoned on to that fact or has worked out all the patterns. So there's some what I'd call bloody obvious stuff about what you might call cognitive behavioural therapy. There is stuff that the psychologists are a bit more big on, and that is giving people strategies which in other realms have been shown to be effective. So cognitive behavioural therapy for anxiety or for depression, there are similar but somewhat different strategies which are quite helpful for those issues, or even for insomnia. So there are ways in which the medical profession, psychology, psychiatry, has learnt to manage those things, and so we adopt some of those things to help manage those issues when they're present.
I think one of the beliefs that was running around...
Can you speak up? I can't hear you.
Yeah, one of the beliefs that was running around when you set it up, and the mention of psychologists being in there, freaks people out because they think, oh, we're going to be judged as to we really have CFS or not. And I've gathered that people don't go there unless they've already been diagnosed, and that from the people I've spoken to who've been through it, the psychologists are there to help them manage it, not to actually psychoanalyse the cause of why they're feeling so exhausted.
Well, you probably... Richard and Sarah might like to comment, but I don't think you can do one without the other. When you say psychoanalyse, again, I reckon that's just good clinical practice that any good doctor or psychologist would do. Working out what's what, helping people to understand the relationships between what they do physically and their exacerbation of symptoms, working out that if they have a blue with their partner, it might cause their symptoms to get worse, helping them to understand when anxiety is starting to play a role and helping them to manage that. So you might call that psychoanalyse it. I just call it good care.
But wouldn't they have to have been diagnosed with CFS and had major other psychological...
Yeah, so let me come back to the issue about how people get into the clinic. It's sort of a downstream issue. Yeah, go on.
Just 1 second. I want longer than that later. In my case, the psychologist went back to my childhood when I was 4-year-old. My dad died when I was 5 weeks old. The new stepfather bashed me for the rest of my life. It was put away to bed, and she brought it all to the surface, my wife will tell you. And now there was a case in the news just last week where Vince Mullen had done the same with a woman in Bendigo. It don't work that way, I'm sorry. It's good, I know what you mean, if they don't get too deep. If it had been left alone for me, I'd have been okay, but to now, I can remember getting bashed when I was 4-year-old, when for 50 years it was away and gone.
So that discussion there is about what I would call largely a side issue. So there are some people who get symptoms quite like chronic fatigue syndrome from what would otherwise be labelled as post-traumatic stress disorder, from either abuse or trauma, either in childhood or sometimes in adult life. And that can definitely cause anxiety and depression, but can also give rise to pain and fatigue. And sometimes people have two things. And so we'd be abrogating our responsibility for good care if we didn't seek to explore that at least a little bit. And so I think if it was key to the resolution of your illness that that bit get explored and managed, I would say that's what we should do. But for most people, that won't be true. And so we can't generalise is what I would say about it.
What happens to the one that is? She's dead.
Sorry?
She's in Bendigo Cemetery.
I hate to tell you, that's an oblique tangent at best. I know having abuse in the household is obviously a bad thing, but we're talking today about chronic fatigue syndrome, and so it's a side issue. I'm sorry. Okay, so let me just get back to the brief discussion about the clinic, and so the evidence base in the sort of published scientific evidence for the sort of things we do in the clinic is reasonably strong. It's got that level 1 criteria. There are multiple groups that have taken reasonably large numbers of patients with chronic fatigue syndrome and delivered elements of cognitive behavioural therapy and in particular graded exercise therapy. Those are the two major components. And each of those has merits. And you probably know there's a pretty famous study that was conducted in the United Kingdom called the PACE trial, which actually tried to break it all into bits. So it evaluated what we'd call pacing, balancing out the supply and demand of energy, graded exercise, cognitive behavioural therapy, and standard care, and compared each one of those in a big study in the United Kingdom. And what it concluded is that graded exercise and cognitive behavioural therapy were better than the other two. So,
what's the name of the study and when was it?
PACE trial, published in the Lancet in 2010, I think, 2011. PACE. If you just Google PACE trial, Peter White was the first author. So that and a whole series of other studies has said to us, look, actually, there's something in this. We've adopted the idea that really the best approach is not to do bits, but to do the whole shebang. That is to identify all of the issues that might be confounding or perpetuating, sleep-wake cycle disturbance, mood disturbance, bad pain control, and then to try and intervene in a standardised but an individually tailored fashion. So what we do in the clinic is that we get people to fill in a whole lot of questionnaires that do two things. One is that they're part of the way we evaluate the effectiveness of the service, but they're also part of the way we individually design and tailor the treatment. So if somebody writes on one of the questionnaires, my sleep's all over the place kind of thing, then we think, oh, okay, we've got to do something about sleep. Or if they say, look, I'm feeling like killing myself every second day, we'd say, oh, we're going to have to do something about mood disorder here, etc., etc. And we get a sense of how good, bad or indifferent they are in a functional status and what the big ticket symptoms are. And then we try and put in place all of those things we've just discussed. So we've put in place optimising sleep-wake cycle, education about the illness, optimising the sleep-wake cycle, managing anxiety and depression, helping people to cope with the chronic illness, pacing their day-to-day activities, understanding the supply and demand equation so they get better symptom control day-to-day, better predictability about what their next day is going to be like, and then graduated increases in both physical and cognitive activity. Now, my sense, without knowing too much about it, is that there's a bit of controversy about the stuff that Monica was flagging. You know, some people are worried about the idea that they might get labelled as having a simple psychiatric or psychological disorder because psychologists are in the loop. And another sort of delicate item is about the exercise. So I want to just say one or two things about both of those things. So with regard to the psychology bit and the anxiety and depression, my sense is, unfortunately, you have to move on from that. That is, this is a complex illness for which we have very poor treatments. And if it was true that you could get significant if it were true that you had significant anxiety and or depression on top of your fatigue syndrome, you will get a lot better, maybe not cured, but get a lot better by having that managed. It's a little bit like saying, I've got bad diabetes and I'm going to take my insulin, but I'm not paying any attention to my diet. It's just dumb. So you're better off having that issue identified and addressed. And that's a little bit challenging, especially in countries like Australia where we don't like to talk about mental health, perhaps other than Jeff Cannon. You know, no one likes to talk about it, no one likes to accept it, but it's out there. And so I have to encourage you to try and move beyond that idea. It is a bit threatening, there's no doubt about it, but it's part of the way in which we help people get better. To be honest, it's back to front, but I always feel reassured when I meet patients who have significant depression or anxiety or sleep disorder, because I know there's a whole lot of room to move to get them better, because they're in some ways the easy bit. The harder bit is managing the fatigue itself. So that's how I put the psychology depression thing to bed. The other thing I would say is about exercise. Now, here I have to talk a little bit about my sense of how it works and how we try and deal with it. And it takes me back to that discussion we were having about the brain and the chemistry. So, you know, I was saying to you that in people with acute infection, they have a lowered threshold for awareness, conscious awareness of sensations from their body, like pain, like the pin being stuck in. We're pretty confident the same thing is true in the prolonged course of chronic fatigue syndrome. So it's like the normal messages from the body when you walk around the block, which should say, oh, I'm not buggered, I don't have any problems at all, I'm feeling sweet. They say, oh, I'm totally stuffed. And so that problem we think arises in the brain. So the problem is not in the muscles, it's not the exercise per se that's the problem, it's the brain firing off inappropriately. Now if that's true, what you'd like to do is have a way to change that threshold. So instead of being able to walk just once around the block, you'd like to walk 50 times around the block, or at least 2 or 3, and not have that bad signal go off until you've really overdone it, like run a half marathon or something. And so the question is, how do you get to that spot? We don't have a drug that can do it. The only thing we know of, and the evidence base is pretty strong here, is that graded exercise can help you do it, both in a physical sense and in a cognitive sense. And what we mean by that is we work out in absolute detail what the threshold is. You know, for some patients it'll be a walk around the block. For others, it'll be half an hour in the gym. And for others, it might even, I've got a patient I look after who's a triathlete, who's like 20 Ks on the bike. Yeah. And she still feels pretty buggered at the end of it, and she's stuffed for a day, but you know, it's 20 Ks on a bike, it's not too bad.
21 the next day?
No, wait for it. So having worked out that threshold and making sure it's reliable and consistent, which we do with activity pacing, the next trick then is to say, okay, somehow or other we have to change that thermostat in the brain to let you get away with more. And there's a kind of a notion called desensitization, where you're progressively, gradually exposed to the trigger, in this case it's exercise, physical or cognitive, and slowly over time try and edge upwards. And when I mean slowly, I mean very slowly, very gradually upwards. And generally what we've found, and this is true from other studies, you can do that. It works. And I don't think it is just fixing deconditioning. I think it's actually changing the thermostat. We don't know that for sure, but that's our impression.
I hear what you're saying about there being a trigger that's to an extent not triggered by a real cause in the body. But I wanted to get your opinion. I know Professor Cheney reckons that when we eat food that the body doesn't convert it to ATP, which is the currency in the cells, and we then do ADP, which is less efficient and harder to manufacture. So how do you relate the fact that we actually don't have an energy currency working efficiently in the body, trying to make it work?
The first thing I'd say is Paul's not a professor. He's a doctor, he's a GP. Secondly, I would say that the evidence for that notion is zero. There's no credible scientific evidence for a depletion in ATP metabolism in patients with chronic fatigue syndrome.
There'd be muscle studies all over the place that would bear that out.
Yeah, so there are some early studies that suggested a little bit of mitochondrial ATP disorder, but really all attributable to disuse, so being less physically active. So no good evidence. Now, I would say it doesn't, we haven't totally excluded the idea there might be an energy disturbance inside the brain, but from the neck down, 100% confident there isn't such a thing. So the other part of the discussion though is about diet and symptoms.
What about the VO2 max studies? Or
Come back to that. So the diet and symptoms. So with diet and symptoms in chronic fatigue syndrome, great dearth of any good evidence for anything. My sense, this is really just from my clinical practices, there is a relationship. But it's very hard to see anything consistent between patients. I've got patients who come in and say, oh look, I eat garlic and it makes my symptoms 10 times worse, and the next patient says, I eat garlic and I feel 10 times better. So I think, well, you know, and so it's hard to understand any consistent relationship, and there isn't any consistent evidence for any diet.
Okay. And just quickly, what about cardiac? Do you think there's a cardiac element to it?
By definition, if you have a cardiac disease, you cannot have a chronic fatigue syndrome. Because having a cardiac disorder means you have an alternative explanation for your fatigue syndrome. They're mutually exclusive conditions. There's a whole bunch of soft, poor quality evidence. There's a guy named Lerner, L-E-R-N-E-R, who thinks there's a cardiac muscle disorder, but unfortunately I just don't think any of it's very credible.
I'm afraid it's time for me to have something to say.
Okay, give it to me.
I've emailed you on numerous occasions. You've always answered me. Thank you for that.
No worries.
Prof Llyde too. I'm a pretty cool bloke, or was once. I was the monitoring technician for 2 large underground coal mines with a budget of over $2 million. I woke up with a gastric and had it for 18 weeks. I eventually made my way to your colleague, Professor Wakefield, who was diagnosed with post-viral syndrome. They put a HD multi-test thing on my arm. I said, well, I passed this bloody thing, there's not a mark on me. There was supposed to be marks everywhere. Without getting into it, you have never once said myalgic encephalomyelitis. Everything you have said about CFS, you are 100% correct. But the ME and the CFS mixed together are 2 different things. The lady that come in, who I think runs the show with perfume on, some of your staff have too, broke out a texter. I think when you come in, you told her to get rid of it. We were moving in the front, we had to come back. That's how sensitive it was. Anyway, there is a patch on my brain from an MRI, a big white patch that size. You weren't too interested in that, and neither was Llyde. But 12 months ago, I fell over. I've been falling over a lot. I had heart check. Subsequent 8 weeks later, I was in hospital with open heart surgery. They changed my aorta valve. There were large infection burn holes in my aorta valve. Blood was leaking out everywhere. I emailed this to you, said very interesting because it wasn't tested and should have been. It was cultured, but it should have been put in a rat, apparently, according to Nancy Climas.
Guinea pig, yeah.
You said very interesting. Come and see me, but I've got a waiting list of 6 months. I said, you can't be too bloody interested if I've got to wait 6 months. I'm already getting the same symptoms, again, shortness of breath and everything.
But sorry to interrupt you.
Let me finish. I've got a pain patch on to imitate that. Now, your qualifications are impeccable. The ladies in America, Mary Schwartz and all of them, The Dubbo study, brilliant. But you're talking about two different diseases. One's myalgic encephalomyelitis, which I've got, and CFS, which you've got. By accident, let me finish. By accident, I was getting sick going to the front gate, wasn't I? And there was a chap in America that was in the Lake Tartu thing, he was mould affected. He said, bugger this, I'm going to try an experiment. So I did. Most of you know Port Macquarie. I walked everywhere to the point where I was that much pain and everything. I collapsed. I went missing. I was missing for 2 hours. My wife was looking for me everywhere. I was asleep in the park bench. At Curry, shut up. At Curry, I walked eventually 3 miles. 3 miles, right? So that part of your fatigue, Trinity, is right.
Sorry, I need to interrupt you now. Because
We do need to give other people time.
so I'd like to just
You
make
want to
a
hear what I say?
Not just
We
now.
haven't got time.
just a couple of comments just to try and generalise from the issues that you raised. One is that it will always be true that there will be patients who will be labelled as having a chronic fatigue syndrome, who ultimately it turns out that it's something else. So I'm sure what I wrote in my email back to you, if you have endocarditis, that's damage to your heart valve from infection, that really plausibly provides a completely separate explanation.
Myalgic encephalomyelitis.
No, that's called endocarditis. It's got nothing to do with myalgic encephalomyelitis. If I just discuss the labels, so chronic fatigue syndrome versus fibromyalgia versus myalgic encephalomyelitis, they are just labels. And what the evidence says about those things... When it starts flashing. Excuse me.
Quiet, please.
No, he's the one who's talking, he's being
Yeah.
What the evidence says about those things is that they're hard, they're overlapping at best. You know, so it's hard to separate them as though they are discrete entities. And that's a phenomenon that's intrinsic to syndromal diagnoses where we don't have a simple blood test and we label the illness on the basis of a constellation of symptoms. There'll always be somewhat grey zones at the boundary. And so we just have to accept that that's an uncertainty.
Can I just ask you whether you agree with... I just find that your theory about brain makes a lot of sense, brain injury.
Yeah.
And I just wondered if you would agree with my sort of thought. You get a bunch of people all in the same car accident. They all end up with different injuries, although they went through the same basic experience. Because having run a support group for a few years now, I've just been gobsmacked by the different symptoms everybody's got. It's not like mumps or measles or flu where everyone's basically got the same symptoms. You've got people here that are in chronic pain. I'm not in chronic pain. I've got a million environmental...
But Monica, I guess the trick about this is that the medical approach to that is exactly the opposite. That is that we look for commonalities. It's a fundamental premise of how we deal with disease.
Why is everybody so different?
Hang on a sec.
We're not that different.
And so, from the point of view of a physician making a diagnosis of chronic fatigue syndrome, there are a list of symptoms that have to be there.
Yeah.
We don't mind if there's a few other variations on the theme, but there's some stuff that's got to be there. If those things aren't there, you don't get the diagnosis.
We've got one woman who couldn't come, unfortunately, because she's in a full-time job. She doesn't spend much time in bed. She's got a million food sensitivities. She feels ill most of the time, but she doesn't mentalise.
But my approach to that issue...
She's been diagnosed as CFS.
My approach to that issue is so they have to meet the diagnostic criteria. From a research point of view, step one is to understand the biological basis of the patients, of the illness in the patients who meet that diagnostic criteria. That's where we have to start. Hang on a sec. We have to understand that first. And then we can seek to understand the variations on the theme. But until you've done the first bit, you haven't got a hope in hell with the latter. So we look for commonalities. We try and identify patients who all have very similar illness. It's part of the reason we set up the Dubbo study. So it's a pile of patients who are all well, got an acute infection, and then had post-infective fatigue.
But they had the same infection.
They had 3 different infections.
3 different ones.
So we're looking for similarities, not
I
differences.
get people who've got parasites.
But that could be irrespective of the...
But they have different
But it's
symptoms.
just a scientific paradigm, Monica. In general, to make discoveries in science, you have to work from like with like. You can't look at the heterogeneity, you have to look at homogeneity. Otherwise you go nowhere.
That was
Well,
an origin.
I have a request to make
apart from the
Would you
fatigue.
please continue with your talk, and we will ask you questions after you have finished.
Yes.
Okay,
Please continue.
I better just let the VO2
I don't want to
max
listen to these
happen.
other people, I want to listen to you.
Okay, I better just let the VO2 max happen. So you're going to say something about the
I just
VO2
wanted
max?
to know what your opinion was. I'd read about this VO2 max thing, and they did the study with couch potatoes and people with CFS, and then the second day the results were that the couch potatoes were better off than the people who had with their oxygen. I don't know exactly, I can't tell you because my brain cannot remember, but there was significant physiological,
There's a bit of a
because of the
technical...
post-exertional
Yeah.
exhaustion, not malaise or fatigue, because it's exhaustion. You know.
So this is describing studies where people are being encouraged in a laboratory sort of setting to do some kind of exercise like cycling or treadmill and to keep going until they're really buggered kind of thing. And to measure how much oxygen they're consuming and as a measure of how the metabolism in the muscles is going. There's a problem with studies like that, especially when they're repeated the next day, and that is that it's very hard to control some two issues. One is what we call volition, that is how hard you try, and the other is that there are some reflex pathways. So if you have pain in your muscles or pain in your body, it doesn't matter how hard you try, it will impair your exercise performance. And so those two things are just impossible to control in aerobic exercises. So 20 years ago, during my PhD, we resolved not to do exercise studies like that because they're uninformative, and so we chose instead to do a more controlled, narrow form of exercise where you just do isometric exercise, just using one muscle group, where you can drive the muscle voluntarily, you can drive it with electrical stimuli over the brachial plexus, or you can actually drive it from a magnet on the brain. And we showed that on day 1 and day 2, absolutely okay. Absolutely no deficit whatsoever in the muscle, in the couch potatoes versus the patients.
So can you explain the grade a bit and how that...
Okay, so we're jumping back now to the clinic and what we do and the evidence base for it. So I've described to you that what we do in the clinic is try and individually identify the magnitude of a various list of problems, how bad the fatigue is, how bad the cognitive difficulties are, what sleep's like, what mood's like, how people are coping, are there other surrounding issues. And then we try and design a program between the exercise physiologist and the psychologist to manage each of those issues. And broadly, that often is fixing up sleep a bit, helping manage mood disturbance, and pacing and then graded physical and cognitive exercise. And I think I was talking a little bit about the physical and the cognitive exercise. So there what we've shown is that you can work out what people's threshold is, so it might be once round the block before they start to get bad exacerbation of symptoms. And you can get them to do that sort of once round the block each day on top of all their other activities of daily living, the stuff you really got to do. And you can do that for a couple of weeks, and provided that doesn't quietly accumulate worsened symptoms, we'd say, sweet, let's go up a little bit. And when I say up a little bit, maximum is 20% above what you've already done. So if it was like a 5-minute walk, we'd say, all right, you're on to 6 minutes. And then you do that for a couple of weeks. And then you might be on to 7.5 minutes. So it's a very cautious increment upwards. I always tell the story of a patient of mine who's a pretty obsessive, nice guy, but pretty obsessive accountant who was pretty badly affected, kind of housebound. I think he was doing about 3,000 steps in a day on a pedometer, which is not very much. It's not much better than housebound. And we'd given him the spiel, and he might have even come to the clinic, and he never really cottoned onto it, just never really got his act together. And then he kind of had an epiphany. He said, right, this is it, I'm going to give this my best shot. And he was heavily into detail. So he started recording all of his activities and all his symptoms, which we get people to do a bit, but just really got very carried away with this. And he came back to me after some months, and he said, Andrew, you've just been giving me really bad advice. That 20% thing you're talking about, totally unacceptable. 6%. He said, I did 3,000 and then I tried 3,000, whatever 20% is, 3,500, something like that, and that just stuffed me. And so then I said, okay, I'll do 10%, so 3,300. Just killed me. 8%, no, too much. 6%, that was the magic number. And that was like 2 years ago, and he was housebound, and he's now sort of 20 hours a week back in the workplace.
What was his original percent that he was given?
I told him 20%.
Oh, okay.
But he said to me, it just didn't work for me. My threshold's just, I'm too sensitive. So I've got to be more careful. Exactly right. But the paradigm still applies. That is graduated increases, and he's slowly but steadily. He hasn't got better, he's still got exactly the same symptoms. Not better, not worse, probably a little bit better if anything, I guess. But still got the same symptoms, it's just that he's doing a whole lot more. And along the way we helped fix up sleep and help him to manage a bit of anxiety he had and put all that together, and that was really the deal.
No.
So the evidence out of the clinic is that if we do all those things, put that package together and do that in what used to be a 12-week and now is a 16-week, 11 visits outpatient program, that people are better, as in their symptoms are less, and that their functional capacity is better at the end of 12 weeks, and broadly it continues to get better. Not like the miracle fix, but tends to improve over time. Not everybody gets better. It's exceedingly rare for anybody to get worse. It happens, but it's exceedingly rare.
Now, how do you follow them up? Have you had a
We talk to them and do some questionnaires.
Because for people here, did any of you get any follow-up after you finished the course, the 4 people?
Yeah, we harass people to send questionnaires back to us 12 weeks after they're finished.
Really?
Ha! We didn't send them back.
How long was the program, sorry?
So it used to be 12 weeks, now it's 16.
Oh, 16.
So 11 visits over 16 weeks, and then we do follow up in 12 weeks later. And then we have a little booster program that Sarah runs, which is like a group. The clinic intervention is generally very individualised, so it's kind of one-on-one. One-on-one with a psychologist, one-on-one with the exercise physiologist, usually back-to-back. But we also run a Getting You Even Better program after the end of that intervention, where people come together in groups and we work through the comparable issues together.
Are there any people here who've done it, like Sarah, you've done it, who didn't benefit or didn't get the questionnaires or haven't done any follow-up?
It's pretty hard to escape without doing the questionnaires.
I mean, sorry? You're still doing the course? Oh, okay. I just wondered how you get your...
I wouldn't call it a course. It's a medical intervention.
Right.
Might be a
I mean,
pill.
with your gamma globulin trials, you had long-term follow-up sort of studies.
I don't think we ever did more than 3 or 6 months post.
Yeah.
Maybe a little.
You're doing the same with this?
Yes.
Do you have follow-up
You're dependent
appointments?
on
I never
people
got
remembering
any.
you.
I never did
Well,
any follow-up.
No, we've only recently introduced
recently,
this
yeah.
booster program, we call it. But we,
Okay, that's a good idea.
welcome to come back. We did that because quite a lot of people said to us that they kind of liked it, they got the gist, they felt somewhat better,
Yeah.
but they felt that they needed more support to keep it going.
Yeah.
Which is understandable.
Absolutely, yeah.
So,
Professor, I've just got 2 quick questions for you. Firstly, how easy it is to get into the course? And secondly, in regard to your experiences, is your course more suited to people that have just been recently diagnosed with CFS or people that are long-suffering standing?
so the 2 questions on the way in, we accept referrals. It's a pretty socialised medicine paradigm we work in. So we accept referrals. We favour referrals under the Medicare, Allied Health and Mental Health Rebate Scheme. That's where your GP writes what's called a care plan, and there's a ready-made one of those on the website, and they fill it in, which basically means put your name on the top and sign on the bottom. They get paid hundreds of dollars for doing that, and then Medicare pays the clinic, the exercise physiologist and the psychologist, or 90% of it kind of thing. And then all we ask is that either from the specialist who's involved or from the GP, that the diagnosis of chronic fatigue syndrome has been reliably made. That's a bit of a trick for us, because all we can really do is say to the GP, if that's who's making the referral, is this really chronic fatigue syndrome? Have you done this list of tests? But our sense is, because with the clinic, it's not manned by medical staff, and so it's not, they're not in the business of second guessing the diagnosis. Our sense is that the majority, 70 or 80% of patients referred to the clinic, for our intents and purposes, appear to have a chronic fatigue syndrome. There are a few that really probably primarily have something else.
And do they then get dropped out?
Depends. Sometimes the stuff that we do is good for people with other disorders.
Post-cancer.
No, you didn't finish the. What's the outcome for people who've been recent? Is the outcome better for people who've been recent?
Oh yeah, thanks for reminding me. It's a little bit of a tricky thing because we know from the Dubbo study and other studies like it that the natural history of recovery is pretty steep early. So if we look at patients who've been crooked for 6 months, who've just met the threshold for diagnosis, about 50% of them will be better at 12 months. That's without us doing anything. Now you might say, okay, that's great, we should intervene right there because then we'd have great statistics at the far end. I think we know from our clinic, Carolina, 5 years on average or something.
5.5, yeah.
So we tend to actually get referrals for the more long-standing, and that's okay. So we wouldn't put any threshold except, notionally having been diagnosed as chronic fatigue syndrome. On the post-cancer fatigue front, basically, just to fill people in if they're not already familiar with it, having a cancer, even if it's cured, and having chemotherapy or radiotherapy for it, maybe plus the surgery, it's very commonly associated with a fatigue syndrome, which for all intents and purposes is indistinguishable from chronic fatigue syndrome. And it runs a very similar natural history. So it's pretty common at the end of treatment and slowly diminishes over time. But it's still about 10% or so at 12 months after treatment. So it's got the same graph of resolution over time.
So it's 10% of cancer survivors who get...
Yeah, we've studied breast cancer, but it's been shown with colon and a whole range of other cancers.
About 10% of the cancer sufferers get this post-cancer.
10% of people who are cured of their cancer,
Right.
who have chemo or radiotherapy to manage the cancer, will still be crooked with bad fatigue 12 months later.
I know this is going to possibly sound
So let me just finish on the cancer fatigue.
This,
so more or
that's
less
connected to cancer fatigue.
same phenomenon, managed in the same way. So we accept referrals for post-cancer fatigue. So
Have you come across it going the other way?
how do you mean?
Where you've got somebody who's had CFS who then gets cancer? And then is
We do have a few
currently-
patients who have a pre-existing fatigue syndrome who get
Yes.
diagnosed with cancer and then have their cancer managed. I don't have enough experience, but I would say, well, generally, predictably, that cancer and its treatment exacerbates the fatigue syndrome.
I went the other way.
Oh, okay, that's nice.
So very nice. Which is why I was wondering about the involvement of the thymus, but I'll talk about that some other time.
Yeah,
I don't know. I've never seen or heard of another patient who got better after chemo or radiotherapy.
dreadfully ill for many years under dry.
Andrew knows me.
Under dry. And then had radiation, was it? For breast cancer. And now she's better than she's ever been.
I love it. I'm not sure I'd advocate radiotherapy as a treatment.
That's the thing, can we advocate radiation?
No, unfortunately.
We did well
Monica,
for the
will
whole.
you please be quiet?
No, so I'm being slightly flippant, but I don't think we can advocate for radiotherapy as a meaningful
No,
treatment.
but it is good news, isn't it? I mean, she was just bedridden all the time.
So let me think what else I want to say. So you've worked it out in the clinic that with that package of interventions, like I was saying, the outcomes are that about a third of people improve quite a lot. And they're on a graph which is generally on an upward trend. We'd like it to go up more steeply. About a third of people improve a bit, and there's a third that are kind of neutral, and very occasionally there's people who don't get better or get worse. And mostly that's because, for whatever reason about the patient or about us, we just don't get the equation right. And in particular, they might exercise too hard and then they get bad symptoms, or mood disorder comes along, or some other confounding issue. What I was going to say is our big ticket, our forward direction about the program is that we'd like to get those numbers better. It's not a great treatment where only a third of the people get a really good response. So we'd like it to be 90%, 100% of the patients get a really good response.
And
so that's why in the clinic we put a fair bit of emphasis on research associated with the service. That's why we make all our patients under great pain and suffering fill in lots of questionnaires, or actually consent to fill in questionnaires and then fill in lots of questionnaires, so that we can try and work out what it is that means some people will get better and other ones won't, and work out how better to optimise the intervention for everybody. You know, if there are some characteristics of some people that are definitely not going to do well, we'd love to know what something different to do for that subset. So our research program associated with the fatigue is very much about how to make the exercise thing work better. Can we do something more about some subset or another to try and maximise the overall benefit?
So do you find the ones who get worse, it's often because they either misinterpret what you want them to do or they're not following the program properly? Is that your general feeling?
Could be motivation as well.
Sarah loved that. She's doing this project on motivation to change.
Well, that's a big factor.
Yeah, I'm sure it is. It's complicated because it's only a very small minority of people who get any worse, and the issues are almost always complicated and pretty individual is what I would say.
How many people have you had go through it?
Carolina? 400 of them?
450, but that was from the end of last year.
When you started in
So
2000,
how many of those people have had long-term, like sort of 27 years? How many have had 10 years? How many have had 5 years?
Average illness length was 5.
Carry those stats in the pocket.
So the average illness length was 5.5 years.
So what happens to the people that have had it long term?
I don't think intrinsically there's any difference between 20 and 5. In terms of the management of the illness and the way they would respond to therapy. It's all about the characteristics of the illness, how well we can identify the issues, how well they can be resolved. I don't think the duration of illness is a bad prognostic sign. It's a bad prognostic sign from the point of view of natural resolution, because natural resolution is closely linked to time since onset. But apart from that, I don't think it matters.
Can I ask about statistics across the globe with
With this sort-
diagnosis? Yeah, it's increasing, isn't it?
Oh, yes, in incidence or prevalence.
Prevalence, yeah.
We don't really know for sure. My sense is probably not.
Oh,
The whole diagnosis has sort of become a bit more mainstream, and so there's many more people being diagnosed than previously. But we've done some research previously which show that the disorder is not bound by geography. So it happens all across the globe. It's not bound by culture. It happens across all cultural groups. It's not bound by language.
gender.
Not bound by gender. Even though the majority of patients in tertiary referral are women, the closer you go back to the community, the more likely it is to be equally balanced between males and females.
really? What, because men are not reporting it?
Yeah, men are not good at accessing healthcare.
So you think it basically it's not the majority of women, you think it's 50-50?
It's possible there's a female predominance, but the evidence for it's not very strong actually. And like I was saying, the closer you move back to evaluating the frequency in the community, like in the population, the more equally balanced it is.
We're just better at asking for help, aren't we?
Yeah. That's really interesting.
But you said with fatigue clinic that the doctors were supposed to sign off to say that, or you were supposed to sign off to say that they'd been clinically diagnosed by having all these tests and things.
Yeah.
Do those tests coincide with the new international guidelines on ME/CFS? Have you
When
got
you
a
say-
list of diagnoses that everybody should go through before someone can say, yes, you've had all the testing done that you need to have done?
It's tricky. You've raised two issues. One is about diagnostic criteria.
Yeah.
So there's the controversial Canadian consensus diagnostic criteria, and there's been a couple of other variations previously. Each of the diagnostic criteria put a bit of emphasis on relatively different things and ask for different tests.
Yeah.
But I would say there's a bare minimum, there's like half a dozen tests that need to be done, and those are the things that we ask to ensure the GPs have done.
Yeah.
The actual process of making a reliable diagnosis of chronic fatigue syndrome, it does require a little bit of clinical acumen.
Yeah.
Because what it really requires is somebody to take a careful history, do a good examination, to think about other medical or psychiatric explanations for the symptoms, and then to be suspicious for other things that they might not have picked up on with a little list of blood tests.
Yeah.
And I guess like all professions, medicos vary in how good they are at doing that.
I think most doctors are pretty bad. No, I'm not saying that badly, because I just don't think that they have the confidence to even think about the level of illness.
Yeah, they've got
that
time
they have.
pressures to, it takes a while to do all that process carefully.
Yeah, so, like for the future, I think we actually need a clinic where we can make sure all the diagnostic things are done, so that everyone can say, oh, okay, we definitely don't have cardiac problems, and we definitely don't have these problems, and,
you're right in a way, although our approach to this is partly what was the underpinning of those clinical practice guidelines that we wrote 10 or 11 years ago.
Yeah.
Because 1% of the population is affected by chronic fatigue syndrome, that's way too many people to have just a clinic. It has to get out there into primary care.
But so if we have a list of things that really need to be diagnosed to make sure that...
that's in the guidelines.
Yeah.
The GPs, those guidelines were distributed to every GP in the country.
Yeah, but the new
All
international ones are slightly different, aren't they?
Yeah. My gentle advice would be, they don't add anything.
Yeah.
They purport to, but there's no evidence that they
The
do.
general feeling of the societies in Australia to the Australian guidelines was their focus on the psychiatry.
There are no Australian guidelines. There is an international diagnostic criteria, which the Australians, the Aussies, were part of, and they are really...
I love learning you guys.
We wrote a clinical practice guidelines, but when we're talking about diagnostic criteria, there's no focus on... The spiel is exactly the one I've given to you today. I could have given the same spiel 20 years ago, 10 years ago, and today. Exactly the same. Nothing has changed. I get branded all the time. When people want to get really nasty with me, what they tell me is that, oh, you're just a bloody psychiatrist. Which in some ways I must say I take as a bit of a compliment. Because it means I do quite good holistic care.
Holistic is the key though.
Yeah, correct.
Can I ask a quick question about, is there
Could you stop talking?
inflammation levels in chronic fatigue?
No good evidence of any change whatsoever.
Okay.
In fact, in some ways, we sort of exclude formally because there's no doubt that...
I just missed that question.
The question was about evidence of inflammation in the body.
Right.
So this kind of goes back to the myalgic encephalomyelitis notice. Itis means inflammation in the organ. So encephalomyelitis means inflammation in the brain and spinal cord. Now that may be present, but there is absolutely no evidence for it.
I also read a paper last week that there is a study proving that there's inflammation in the brain of most CFS patients.
Don't know what study it is you're talking about. I know of no evidence.
So it was a very small study.
Using what technique? Do you remember?
PET.
Okay. So what I would say about
9 people, and they found that in various sections of the brain there was inflammation process taking place.
So it all depends on what the
I think there were
ligand.
9 people.
It all depends on what the ligand for the PET was. Because so PET is radioactive isotope labeled proteins binding to something or other inside the brain. Most commonly it's done with glucose as the ligand, and that just says these cells are metabolically active. The 21st century PET scans are based on proteins which we know bind to specific receptors inside specific cells in the brain. So if the ligand is based on binding to, let's say for instance, microglial cells in the brain, I would pay it as soft evidence for inflammation in the brain. I kind of believe that there may well be. There's definitely no evidence for it in the spinal fluid.
Yasuhito Nakatomi is the lead author.
Oh, good on you.
Neuroinflammation in patients with CFS and encephalomyelitis, 2014. I can read you the abstract if you like.
No,
It's
that's
very
great.
technical.
I'll send it to you.
Where is it?
JNM, I think, the Journal of Nuclear Medicine.
Okay.
So Nakatomi.
Were you going to get your physiologist or any of your team to talk to you?
Yes, this is it. I'd love to hand over to them.
I'm scared you might rush off.
So maybe do you guys want to ask the team about some questions about the nature of the intervention and how they manage it?
Maybe
Carolina can talk to you about
maybe
exercise and how it works.
talk to us first and give us some demonstration.
Good idea, Carolina. You're on.
Thank you, Professor.
Just say something.
Do an interpretive dance.
Give us a demo of the workout.
Hang on.
Well, actually, thanks for putting me on the spot, everyone. So I guess that's the first thing that is important. We don't actually do any exercise at the clinic.
No.
And that's the first thing that's really important because...
And your name, sorry?
My name's Carolina.
Carolina.
And why that's important is because we know that actually the nature of the illness is that there's a fluctuating nature. There's good days and bad days. And if we get you guys actually on a day where you're not feeling all that well, the last thing you should probably do is exercise. And also if you spend an hour talking to the psychologist and then come spend half an hour talking to us, what's likely exercise going to do is just exacerbate symptoms even further. So that's the first thing, is that we don't actually do the exercise in the clinic. The other thing is that where all the evidence is at the moment is not in, when you said, for example, a workout, you might think of doing squats or push-ups or that kind of thing. Yeah, I know. But I guess the idea is that we don't do those kind of musculoskeletal, because actually, like Andrew said, the evidence is not that the problem's in the muscle. And it might feel that it's weak or that it's heavy, but because we're trying to deal with a problem in the brain, that it's like a problem with desensitization, we will work on those thresholds. And what we try and ask people to do is what you're interested in. Do you like gardening? Do you like swimming? Do you like cycling? Do you like shopping? You know, whatever you want to do. And the idea is that we, first of all, sometimes we don't even do exercise until halfway through the treatment. So, and I always say to the patients, the exercise actually is the easy part. The hard part is the pacing. The hard part is finding out how you're going to have good days and bad days, and what kind of steps are you supposed to look at. And it's not just the steps, we also have to look at the cognitive component. You know, how much are you stressing in terms of cognitive load as well. And so, from my point of view, in terms of prescribing the exercise, the first thing is to find something that the patient actually likes to do. The only rule that I have is that it has to be, when we say cardiovascular, all that really means is using large muscle groups. So it doesn't mean that people are huffing and puffing. Actually, we don't want people to do that at all. It just needs to be very gentle exercise, and our primary focus initially is duration. So really paying very close attention to how long patients can do a particular exercise for. And that might mean starting at a 10-minute walk, and maybe not even every day. It might be twice a week, every non-consecutive days. It just depends on the individual circumstance. So if someone has a child and they need to do the shopping, well, there's your exercise for the day. You have to go do the shopping. And then if you've got to do work, then you're doing a whole bunch of cognitive activity. So I'm not going to make you do exercise on the same day. Eventually, we will try and get to that spot. But initially, to start off with, we need to look at the big picture. And then once we've done that for a couple of weeks, we look at increasing. Now, maybe it's the 20%, maybe it's the 6%, it depends on the individual. But the idea is to slowly push a little bit further, making sure though that sleep is okay and mood is okay and pacing's still happening.
I'm just wondering if we could get someone like Louise who's been through it and found it quite helpful. Would you like to come out and just talk with Carolina about how you fit it in with what she's saying? Come on.
I remember Louise.
Oh, do you remember?
I remember
Tell us
Louise.
how you because you did
That's a few years
seem
ago.
to benefit from it, didn't you?
Yeah, I thought it was good.
She goes swimming in
I
winter
did.
and stuff.
Well, it's all the little things that you sort of
Come
picked
face
up.
the camera.
Yeah.
Come face the camera, Louise. Share the spotlight.
Her husband's
I'm too tired now. I don't like cognitive.
Yeah. What,
So,
what did you do that increased each
I
time?
think I did walking. I remember specifically what you're saying. So I did it 3 times a week, and I think I did 10 minutes for 2 to 3 weeks. 10 minutes 3 times a week for 2 to 3 weeks. Does that make sense?
Yeah.
And then I increased it by 20%, and I did that for another 2 to 3 weeks, and I did it gradually up to 30 minutes. And then I could start on the off days. Like I did that on the Monday, Wednesday and Friday, 3 days a week. I'd go on the off days, on the Tuesday and Thursday, I'd start from the 10 minutes again. still doing the 30 minutes in those other days, if that makes sense.
No, sorry.
That's perfect.
Yeah.
Sure, money.
Well, the
I still
secret.
remember it, and some days if you shop, you don't do anything else. And like you said, everything comes out of the same fuel tank. So if you're reading or writing or anything where you're concentrating, it doesn't mean that you can have a rest there and go and take a walk, because it all comes out of the same fuel tank. So, yeah.
On the money. On the money.
So you only do one of those things because that is an exercise in itself, the cognitive, as opposed to exercise.
So how do you keep tabs? Like if you're reading or writing, you sacrifice that. You sacrifice your walk to do those things. How do you measure?
So what we try and do is actually not about sacrificing, it's about kind of scheduling and organising. So that you don't have to always miss out on things. It's more about having a structure. Now we might do that depending on the patient. So it might be in terms of a physical sense, we try and get people to orthodontists. Because it's not perfect, but it's actually a pretty cheap way, but a nice way to look at how much incidental activity you're doing. And every now and then,
So you write down your steps from the pedometer each day, and you can see the graph what your move was like. Like if you did 2,000 steps or 3,000 that day, you might be okay. And you can see the adjustment in your mood and how you felt and how you slept if you've done 7,000 steps. You know, you can really picture where it's gone down. It really makes you
So
see
what
how
was the difference between that? Because she then finished the course, then went off to some osteopath that did something amazing with her, and that made
that's just something. Yeah, that's just something that's worked for me. It's just another.
How much better were you before you went to the osteopath compared to before you went to the clinic? Like how much difference did the clinic make to your overall CFS?
I felt it did work because it's such a slow pace.
Yeah, it was a
20%.
journey.
It's just a slow, long journey, but it does work.
And you've been able to
It's
keep
the hard
up,
sticking to it.
and you've been able to keep up that discipline.
Well,
and
we did
pacing.
go away for 3 weeks overseas, so that sort of knocked me back a bit. But I knew that. And I was aware. You've got to be aware of it.
So it changed your attitude towards
Yeah,
things.
yeah.
The way we kind of tell patients at their first visit is that this process is about understanding your condition and giving a bit more of control. You know, if actually my goal at the end of the 16 weeks is, I don't really care if people are walking 30 minutes or if they're walking 10 minutes, is if you know how to continue to progress. And what happens if you go overseas, and understanding that sometimes symptoms are going to get worse, and it's okay, and doesn't mean you have to start from scratch, but kind of how to manage that a little bit better. So in terms of understanding, I think that's
Yeah,
what
you've got to realise how long, you may only do 5-minute walk and then build from there. But as soon as you get the first symptom when you're walking, that's when you time it, using your watch.
When she was going swimming in winter, are you still doing that?
Swimming?
Swimming every day in winter as well
Oh,
as
yeah,
summer?
2 or 3 times a week. I find
Well,
it.
that's fantastic, because she didn't come to our group for 2 years, she was so sick, and then she suddenly came back all fired up. Has anybody else had any success stories from the clinic who finished it? Be nice to hear.
I'd say I've done it. I wouldn't say it was a success story because I'm still really
Can you come
struggling.
out and talk to the camera?
Can I just say one thing while this lady comes up to the front that I don't think is being stressed? The clinic is a very collaborative program, so we listen to what you're missing out on and what you want to reintegrate back into your life, and then you try and manage activity from there. So you're in the driver's seat, we're just there to give you the tools to put into action into your daily life.
It's nice having role models. This is Kathy.
Yes, I'm Kathy.
When did you do it? 2010?
2010, I believe. I thought it was very valuable, like you say, for understanding the illness and to really break all of your activity down to basically nothing. So when you do those activity reports and you note down what you've done for a week or 2 weeks, and you come and see Carolina, and she says, "Are you crazy? You're not well enough to do all these things. You really have to." No, but you don't pull your punches when it comes to, you're trying to do too much. You have to scale it back and start with really what you need to do. Kind of really work on the scheduling. The pacing has been really good. I still work. I run my own business. Some weeks I don't get very much done at all. I work from home, which is fantastic for me to not have that commitment to travel or to have to be on for other people all the time. But touch wood, still running the business. Have had some periods of almost recovery and thought that I was there for maybe 3 months, and then it's come back. So at present, not great, but still running the business.
But overall, the change in your attitude towards everything was what was brought about by the clinic, and taught you to pace yourself better.
Definitely taught myself to pace myself better, because I had no idea when I started. I'd only just been diagnosed, even though I'd been ill for years, and it had taken so long to get to that place of having a diagnosis. And I was still trying to fit in with a normal model of what I expected of myself to do. And it really just broke that right down. And Carolina would say, well, you know, if the floor doesn't get vacuumed that day, too bad, you know, let it go. It's not like about having to get all those things done that you expect. It's about doing what you need to do to keep yourself healthy and to get into a routine and to understand your body. So I'd say that it's certainly not helped me get a cure, but it's certainly helped me understand it and to be able to read my body and to not set myself up by trying to do too many things. Like, I won't set meetings for consecutive days. I'll try and spread them out. Maybe once a week I'll go out and have a meeting with a client, and I know not to try and do too much. Or that if I have to do too many, then the next 2 days maybe the phone gets turned off and people just have to wait until
See, one of the reasons I've been scared to go and do it is because I'm an obsessive. If I start something and don't finish it, I just live in fear that I'll never get back to it. And I've got a million unfinished things in my flat.
Yeah.
And I just will keep pushing myself to the point of complete burnout to get something finished before I go to bed. And I know it's my Achilles heel, and I'm just scared. No, I did the Bruce Campbell course. I don't know if you're aware of the Bruce Campbell one. I did that last year and failed it spectacularly. I was told to set the most minimal goal, which was turn my break reminder on my computer off every 4 minutes. And I just failed it completely, and I really lost confidence in myself.
I think we've got a couple of success stories though.
Yeah, I know. It's
Can I
very
ask
encouraging.
a question, please? Concerning people who are very severely ill, bedridden. I was reading on the CDC website about graded exercise for them, and they were talking about brushing teeth, the exercise, and just going and having a shower at the exercise. So graded exercise does not necessarily mean that you're running marathons, as is the prejudice of a lot of people who are afraid of talking about graded exercise.
Yeah, our paradigm, I think, is broadly applicable. Because we're an outpatient clinical service, people have to physically get to the door. We're intrinsically biased towards people who are moderately functional, I guess. I do have a small but significant number of patients who are, basically bedbound, but the paradigm is exactly the same. We just make the milestones much, much smaller. If anything, my sense is that group, either because the biology of the illness is intrinsically more severe, or because the confounding issues are more complicated, it's a harder call. It's a longer, slower road. But the principles, I reckon, apply perfectly the same.
Yeah. Part of what I'm trying to get under here is that there is a prejudice within the CFS sufferers community that when you go to get treatment and they're going to suggest graded exercise, that this is something horrendous and it's going to be bad. And it's going to make them worse.
My sense is, though, the devil's in the detail, because I continue to receive a steady supply of referrals from general practitioners who might be well-intentioned, who said, yeah, I think you've got a chronic fatigue syndrome, you've got to get out and exercise. Yeah. And so they're told to go to the gym or something like that, and they try and do that religiously for days or weeks, and then they're pretty bad. And so I say, look, there just wasn't enough attention to the detail. The thresholds have to be worked out, what's okay, what's not okay. And once that's sorted out, then you can apply the principle really well.
I think activity, the word activity, might be more acceptable than exercise, because so many